Current efforts to change Scottish primary care are shaped by a range of influential policies, strategies, and examples of best practice. To be successful, each of these would require that primary care increasingly engages people in a different way. Why is that? General practitioner stress and morale may be at breaking point. The primary care workforce is ageing and recruitment is not keeping up. Patients represent an ageing population with increasingly complex needs. What do we mean by complex needs? British medical history over the last 200 years is conceptualised by some as having had 4 waves building on one another. Civic works and sanitation, emergence of medicine as science, social changes leading to the welfare state, then efforts to combat disease risk factors. This would leave an emerging need for a 5th wave, one that can start to tackle our modern epidemics: depression, anxiety, dementia, obesity, drug use, alcohol dependency, diabetes, chronic illnesses, a range of mental health issues. 40% of adults in Scotland are living with at least one long-term medical condition. It is this that makes patient needs increasingly complex in primary care. If a GP traditionally has 3 options for a patient sitting in front of them: prescribe, refer, or do nothing, how many of these 5th wave needs can realistically be fixed? So how do we begin to think in a new way? This is a question that's been explored by Community Renewal, a Scottish charity. We bring expertise from outside the medical community, from asset-based community development, from improving lives in deprived neighbourhoods. The 3 core principles we've been starting with are moving away from a fix-it approach when it comes to these 5th wave epidemics, changing the balance of power between professionals and the people they serve, and creating conditions for patients to shape their own health. In primary care, this has led to tests of new ideas across 2 interlinked strands of activities. The first looks at the GP practice as part of a wider community of health. The second helps disentangle patients' medical and non-medical needs with a focus on activating self-care. First of all, looking at the GP as part of a wider community of health has meant that Community Renewal has been working with a range of staff in individual GP practices to work one local community at a time. Then with each community and practice we consider what services, groups, networks are already out there. Can we ensure that there's an up-to-date mapping of all these community assets? Can we invite them into the GP practice? Can the practice build relationships with them to develop mutual understanding and support paths? We've had staff just sitting in waiting rooms, listening to patients' needs and having conversations with the patients about how they might get the best out of the services offered at this GP practice. Do they really understand who to turn to and when? We've spoken to patient representative groups or focus groups of people with shared needs. In particular, we've listened deeply to the needs and wants of patients who've been attending GP appointments most frequently over a long period of time. We've also looked at shifting front of house staff in a GP practice from being gatekeepers, keeping patients out of the practice, towards them taking on the role of a community navigator, signposting people to effective support. This range of activity to embed the GP practice within a community, engaging local services and local people, has led to some early examples of positive outcomes. We had a conversation with one man who'd been attending one of our GP practices every week to get a nurse to apply some skin cream and also for a GP consultation. He disclosed that the only speaking he did all week was to the nurse, to the GP, and to a photo of his deceased wife. He's now being connected to a men's shed project where he enjoys the activity and he enjoys the socialising. And he no longer comes to the GP practice for regular appointments, not even for the skin cream to be applied. This example ties closely to the second strand of activities which Community Renewal have been exploring, around disentangling medical and non-medical needs in the first place. We've been developing training and tools with and for GPs and for allied health professionals, including what we call the holistic assessment process. The holistic assessment covers patients' social and family situations, their current level of self-care, their work and finances, and critically, their longer-term hopes for their own well-being. This assessment process is a listening exercise and leads to a plan agreed by the patient. Even though this process takes the form of a longer appointment, we found that many GPs embrace this with enthusiasm as they can see the difference, especially with frequently attending patients, and the demand for appointments for follow-ups may be significantly reduced. As a further example, one of the GPs who attended our holistic assessment training described one of his female patients who had accessed primary and secondary care 44 times over the 5 weeks previous. At this point, a holistic assessment conversation was used. The plan for her care that she came up with focused on spending more time with her sister, who could provide some care and some emotional support. Over the following 12 weeks, she did not attend any unscheduled appointments. Clearly, this interaction draws on the 3 principles, moving away from a fix-it model, shifting the balance of power, and creating the conditions for the patient to shape their own health. It was not a health interaction where another prescription or a referral within the health system could ever have fixed her needs. Another question that the Community Renewal pose about interactions such as that above is when she walked in to the GP practice. Should the GP greet the patient with the traditional line, "Hi, how can I help you?" "How can I help you?" goes against the new core principles. It suggests the power is with the GP, that they could provide a fix. So perhaps an early indicator of the successful embedding of our new principles is when we hear GPs greeting patients with new phrases. "Hi, what would you like to get out of the session today?" All this work by Community Renewal has really just been exploring and testing ideas. The evidence of need for change is overwhelming. That the response involves engaging people in a different way is clear. All we can conclude about solutions is that many small and subtle changes seem to help, crafted around each individual GP practice and constantly reflecting on the 3 emerging core principles.